My name is Abiye Hector-Goma. I'm a general practitioner in Leeds, and I've done this for nearly 20 years. I've been a doctor for 35 years, and I came into Leeds to do a master's in health promotion in 1997. And from then on, I worked for heart research in Leeds. And then one day I had an opportunity to go to the House of Commons as part of a presentation by the charity to the MPs and the lords and baronesses. And then I was in charge of lifestyle education in the charity. When I came out of the House of Commons and I was walking to the train station, this was about 1999 or 2000. I wasn't then working as a doctor, and I said, wow, I came from Nigeria. I've had a chance to be in the House of Commons and all of that. They call me doctor, but I'm not practicing as a doctor. It's time to get back into my profession. So I went and did PLAB from the floor. I was a year to becoming a consultant in Nigeria before I came to Leeds. And here I was now going to do medical exams. And then I started from the floor of medical practice and worked my way up to becoming a GP in 2006. If I ask myself a question, what are my challenges as an African or person of African descent? And I use that as a blanket term. I'm not very much into black. I like the word persons of African descent. So both those of us who've come from Africa and our brothers and sisters who have come from the islands, I say the first thing is our color. You are seen as your color. Whatever you do is brought down to your color. So if I'm excellent as a GP, I'm seen as a black doctor. If I sing very well, say that black musician. But if the other person sings very well, say, oh, Sandra is a lovely musician. But if Hector sings very well, say that black doctor sings very well, that kind of thing. So that becomes an issue. And I think it's been difficult. I wasn't here when you had no blacks, Irish, or dogs. That was, I mean, a very challenging era. And so I think it's difficult. People who have traveled around the world are more open. Many people have not traveled around the world. And so generally, opportunities are few and far between for people of African descent, as well as our brothers who come from a South Asian background. So you kind of more or less have to struggle to get anything. And I understand that because coming from Nigeria, there's a lot of tribalism even in Nigeria. So you have the Igbos, Hausas, Yorubas, the Ijaws. If you come down to even River State, Nigeria, where I'm from, you even have the upland rivers and the riverine rivers challenge. If you come into my community, Okrika, you have there are 9 clans from Okrika. You have those challenges among the 9 clans. If opportunity comes to the 9 clans, one clan has a dominant over the others. So all those things are not new. So coming here and you find the same thing about the inequality, we're used to that. It's expected, but it's not right. So people have to work twice as hard. As person of African descent, you have to be 2 or 3 times as good as the white person to be able to get an opportunity. But I guess that's how it is. And I think the more we get into the system, as they say, if you're not on the table, you're on the menu. And as more of us get on the table, then we're able to put a voice for ourselves. And that's why it's really important for us to get on the table. Just talking about mental health as one of the long-term conditions we deal with in primary care, of course, as a society in general, I like to look at things from the root of the problem. When you have somebody, for example, let me digress a bit. Somebody has a fever, and for back in Nigeria, that fever may be caused by malaria. Now you can give that person paracetamol because of the high temperature. So that's like if you look at a tree, you have the roots, you have the stem, you have the branches, you have the leaves. So giving paracetamol to somebody who has a fever, which is caused by malaria, is probably dealing with the leaves of the tree. The root of the fever is malaria. And if you give the person anti-malarials, you're probably dealing with the stem of the problem because the root of the problem is probably because of the environment where that person lives. There's a lot of bush, there's a lot of stagnant water and things like that. So if you're able to clear the place of bushes and there's no stagnant water, water is flowing, it's now less likely that you're going to have breeding grounds for malaria. So bringing that back to something like mental health, giving people an appointment with a mental health practitioner, a psychiatrist, is fantastic because you help them to kind of you treat the symptoms of their mental health problem. But for many of them, the root of the problem lies in poverty and lack of access to education, to housing, to skills for employment, and of course, people have genes sometimes. Some mental illnesses may run in families, but sometimes genes have to interact with the environment. So somebody who has mental illness or who has a gene for mental illness, who does not smoke, who has proper education, who has access to exercise, who has peace in his mind, who can play where he wants to play, that person is probably less likely to manifest mental illness than his brother or sister who has poor education, no access to jobs, lives in a horrible home, and then finds solace in alcohol, drugs, smoking, and all of that. And that's why I like to look at the root of the problem. If you look at this house where we are, we can't see the foundation. The walls, the roof look good, but the foundation is what really matters most. And that's why I always want to ask, what is the root cause of a problem? Let's take it all the way down till we get to the roots. And if we can solve the problem at the roots, then we're going to have a permanent solution to that problem. Talking about mental health diagnosis, I have been kind of curious. I am the lead GP for Westfield Medical Center and Allerton Medical Center, which have merged. We have nearly 10,000 patients, and Westfield branch of the practice is situated in Chapeltown. And Chapeltown PCN, I was the clinical director for the first 3 years of Chapeltown PCN. So SMIs, or serious mental illnesses. In my practice, we have 141 patients who are on that register. And SMIs in our patch of leads, there are about twice as many people who have SMIs than the rest of the city. And I'm interested, in terms of, people who have been diagnosed with schizophrenia and so on, 20, 30, 40 years ago. Let me digress a little. Hypertension diagnosis 40, 50 years ago was it came to my clinic, I checked your blood pressure, it was elevated above what we consider top of normal. I wait for about 5 minutes. If I check it again, it's still elevated. I make a diagnosis of hypertension. But that has changed now. If somebody's blood pressure is raised like that, we would give them a blood pressure monitor and a sheet of paper to check it twice in the morning, twice in the evening for 7 days at home. And then we check the average. We've come to realize that many people, when they come to see a doctor, they're running late, there's nowhere to park, they waited for a long time, and that can get their blood pressure up, the so-called white coat hypertension. So people who were diagnosed with hypertension 40 years ago, with this new system, and in other places you have the ambulatory blood pressure monitor, you have a machine which is tied to your arm for a whole day, and it just measures it. Those that can't do that now give the one that you do for 1 week at home. That has changed how hypertension is diagnosed. And a lot of our fathers and uncles were considered aggressive. When we talk with a lot of passion, a lot of energy, we feel we are being oppressed. You raise your voice. Sometimes it's just enough to raise your voice once or twice, and then you're labeled as being schizophrenic. So I wonder, we are people diagnosed with schizophrenia because they did not fit into your expectation. Maybe the person is living in a damp house, they go to housing office and they raise their voice, say, look, this house is cool, man, and all of that. And then somebody is upset and then send to see a psychiatrist, and then he talks, he raises your voice some more, and then say, yes. So I wonder, can people review the diagnosis, the criteria, and then see how things are? And like I keep saying the same thing again, the schools, the skills, the employment opportunities people have, I'm sure has a contributing effect. And my brothers are probably going to raise their voice when they feel they're being victimized and oppressed, and that could mean schizophrenia. In terms of stigma, oppression, racial issues, inequality, the when you look at the whole spectrum, you find that poor people are everywhere, whatever race or color, they are poor people. In my practice, you have people of all races who are poor. But when you now look at opportunities to make a difference, you now find further segmentation. So when you finish with the Caucasian population, the South Asian population is the next in line, and the people of African descent are the last in line. And I think if you even break down further, the African Caribbean is one step ahead of the African, even in that pecking order. And I believe that I know. I mean, Michael Marmot's work resonates for me because he talks about giving every child, and that every child, you underline it, every child in the United Kingdom should be given the best start in life. And if government is able to put their money where their mouth is and put resources where the need is greatest, and every child starts from life begins at fertilization. If life begins at fertilization, the adolescent girl, how healthy she is will determine what kind of child she's going to carry. So, from the health of the adolescent girl to the antenatal care that is received, all the way to birth, labor, birth, the early years, those investments in the first 6 years of life, starting with the pregnant woman, I think if there's a kind of equality in that, in resourcing the first 6 years of life across the city, I think we're going to have healthier people, and there'll be less, racial, should I say, divergence in people's abilities in life later on in life. In the mental health space, I'll be honest with you that I do not think much has changed in the mental health space from a personal point of view, because unfortunately, as GPs, we are overwhelmed. That's the truth. Unfortunately, we're overwhelmed as GPs. And I say this with a lot of sadness in the sense that there are so many of us who know what to do, but you don't have the space to do what you want to do or what you think you need to do. For example, I like to work more with my patients and my community. I'm lucky to be a man of African descent working in a community which has a large ethnic minority population. I think it's about 69%. So that kind of thing, I want to spend more time doing stuff in the community, be part of the men who go to West Indian Center, play football here, just be around the people and influence them informally. But I go to work first thing in the morning sometimes. I'm there at 7:30. At 8 o'clock, I'm dashing out of the office. I come home, I eat, I put my laptop on. I'm trying to catch up with labs. There's hardly any time to do what you need to do. So that's for me, it's a sadness that one is so overwhelmed by what they call a Groundhog Day or just doing the same thing over and over. But I really want to spend more time working with people who look at the foundation of the problems away from the medical space. These are socio-economic challenges that bring about health problems. And I want to work in that space and do more of that, bring more investment to the primary schools in Chapeltown, look at what's happening in the communities. If there's going to be a skills center where people can learn zeros and ones or whatever, bring it to Chapeltown, bring it to Beeston, bring it to Hare Hills. Let some of these things be happening. If schools are failing, look at the schools in the inner city. Why are they failing? Put investments in those schools to transform the education of the children there. So that's the kind of thing I really want to do more of. But I think it's good that I'm there because people know that their brother is a lead doctor in the area. And I guess for the younger generation, that it shows that there's hope for them to seeing one of them as a lead doctor in the community. On the positive side, I think there's a lot more acceptance that there has been inequality across health, across social care, across education. there's a lot more awareness. Before you could pretend it wasn't there, but you can't pretend anymore. So that's a good thing. And the fact that when you look at like the primary care networks, there are a few of them where people of South Asian or African heritage are lead doctors, which is actually a good one. So on the plus side, there is increased awareness. But I guess the challenge for me is again coming down to when you're not on the table, people would try to find solutions to problems based on their understanding. And in most meetings I'm attending, when it comes to things like SMI, again, our diabetes population, again, in Chapeltown is almost twice what it is in the rest of the city. SMIs, diabetes, a reflection of deprivation. So I always say, let's not treat the symptoms. Let's go to the root of the problems. And root of the problems means investments in education, in housing, in skills for employment. That is where there's more lip service. It's very easy to put people in employment to provide services. But I think getting to the root of the problems, if we're not there, those conversations will not have held, you know. So that's one thing I think is one of the things that one is quite proud of. And then the other thing that I would say is that because I wasn't just a GP in a practice, I was very much involved in the community space. So I was involved in the community, in the Nigerian community leads. I was very much involved in the church space. I was both a trustee at Redeemed Church of God in Leeds as well as New Testament Church of God in Leeds. So whenever there were health conversations, I was able to do those conversations in the community as well as in the health sector. So that again was something that one is quite proud of, not just in the public sector, but in the community sector and the voluntary sector. I wear these prints to work. Um, I know exactly that there's a lady called Ngozi Wela. She's the Director General of WTO, World Trade Organization. She's a Nigerian, and she always dresses in Nigerian outfit, wears a scarf. She has that trademark. And I think about 4 years ago, I just thought, wow, unconsciously, I just went home and got some prints, and I got four of them, and I wore them. And then from then on, one or two patients will say, "Oh, you look nice," and then some will say, "Oh, I feel better already." And then after then, I got some more. I had about 14 of them, and it was summertime, so some people thought, okay, maybe it's a summer thing. And then winter came, and I got some more. I think I have about 30 tops like that. And that's what I wear all the time. I mean, I had about 30 shirts and ties. I packed them all up. And in the last 3 years, this is what I wear to work. And I always feel good when a patient says, I feel better already. When I wear some bright colored ones, say, wow, this is really nice. And that kind of gives me a sense of identity. And I remember somebody told me, one of the leaders in the health sector in the city referred to me at a meeting he had with people of minority ethnic communities, that why don't you people have your identity, because Hector, you know, always dresses like that. And I think that brings me to a very important thing that matters so much to me, that united we stand, divided we fall. People of African descent, whether originally from Mother Africa or those who are in the Caribbean, there's need for us to come together and be united, because I won't say anybody is dividing us, but because we are divided, we cannot speak for ourselves. And I say this even in Africa, as who are Africans here. Nigeria is the big African country, and I know that there's always a tension between Nigerians and Ghanaians and other people. So we as Africans, we have to know that we are brothers and sisters. We have to come together and be united. And then those who are people of African descent, who are from Africa, and our brothers who are African Caribbeans, we need to come together and be united. And when we are united, we can speak with one voice for our children, for our wives, for our sisters, for our mothers, and make sure that we work together to address the socio-economic challenges that face us more than most other communities in the city.